Okay, next up, pediatric cardiac disorders. This is stressful for all of us, right? Because we don't see this that often. But let's talk about some of the basics that we need to know. So CPR Basics. Initially start off, confirm that they are truly apneic and pulseless.
That is truly basic.
That is truly basic. But it is a little bit more tricky.
Yeah.
I have great pulses in my fingers, so this table has a pulse for me right now.
Yeah.
So confirming that that is the case, certainly erring on the side of starting CPR. And I think a unique feature with children that we'll emphasize in a couple slides as well is that you are going to start compressions if their heart rate is less than 60.
Yes.
Kids are very, very respiratory dependent. So initiating rescue breaths and CPR early, certainly err on that side. I think overall, we tend to not give compressions hard and fast enough. We tend to err on the side, we're a little bit too gentle about that. So make sure that you're doing good compressions, deep and fast. But we also tend to breathe a little bit too fast. We're excited, so we breathe too fast. So there's a little bit of conflicting data between the AHA as well as the international consensus on how fast to give breaths. We'll say the AHA says 20 to 30 breaths per minute, but 10 breaths per minute. So there's a little bit of controversy there. I'll say probably slow it down. We tend to do it too fast. As I mentioned, compression rates, pretty fast, 100 to 120 pumps per minute. And you want to compress 1/3 of the chest wall. So in an infant, we get more effective compressions if we circle the chest and use our thumbs rather than that 2 fingers. So you want to get good compressions. So sing, staying alive, the rhythm to help keep you going faster. Access is a big problem, particularly in the young. They have very difficult to find veins. Often they're chubby. They may, when you need critical access, they're often dehydrated, sick. It's a stressful situation. So just have an algorithm ready. And remember, in that first week of life, you can use the umbilical vein. It's basically a transected vessel, and you put a catheter in. The procedure itself is not all that difficult. You basically want to get it in that the larger structure, sort of, you've got 2 eyes, the umbilical arteries are the eyes, and that vein is like the bigger mouth. You want to put it in there, and you put it in about 5 cc's on average. You basically put it until you get blood back, and then
You mean 5 cc's, 5 centimeters?
I'm sorry, I meant
right.
5 centimeters.
Yes,
Thank
okay.
you. Yeah. You put it in about 5 centimeters, usually 4 to 5 centimeters in a term neonate, but you put it in until you get blood flash back, and then advance it a centimeter or 2, and then you can use it. It's a great access. IO access, you can put IOs even on preemie babies. That's really important to note. I've noticed clinically that if I have a little tiny baby, a distal femur, putting it in the distal femur is just better if I'm using the gun, because they don't have that much muscle there. I'm not putting a distal femur IO in an adult. That's not very feasible. But in a little baby that doesn't have a lot of muscle there, that tends to work really, really well. You can give any medicine, any drug, any fluid in an IO. And because 95% of all pediatric cardiac arrests are of respiratory etiology, focus on the airway. Airway and breathing, really, really important in neonatal and young infant resuscitation. Bradycardia. By far the most common etiology of bradycardia is sinus bradycardia, usually secondary to hypoxia. So if you see this arrhythmia, all the atropine in the world isn't going to fix the problem. It's oxygen. You need to correct the oxygenation. And they're anatomically and physiologically predisposed to hypoxia. You can really collapse the airway just by laying the big tongues, floppy tongues, epiglottis, all of these things. So position the child, give them supplemental oxygen. And then a really important point, start CPR if their heart rate is less than 60. Start those compressions.
So even if they still have a heart rate, we're starting CPR, which is different than adults.
That's different.
So,
That's very different.
And I think you have to sort of fight your instincts on that one,
Yeah.
because if you see rhythm on the monitor, you're like, well, I think they still have a pulse. No. If their heart rate is less than 60, go ahead and supplement and try working on that airway. That's going to give you your best chance.
Yep.
Yeah. So if you haven't reviewed PALS in a while, here's your bradycardia algorithm that walks you through this. Make sure you have your IV access. Look for all those signs of poor perfusion. If the heart rate is less than 60, and signs of inadequate perfusion are there, go ahead and start your CPR, and then go ahead and go through your algorithm. So it's going to be epi, it's going to be atropine, it could be transcutaneous pacing, although I've never really seen that done in a kid. But really you want to focus on the airway. I think that's exactly right.
That is, the airway oxygen is going to solve most of the problems.
Yeah. Now kids are really responsive to epinephrine, so of all the drugs that you're going to give, whether or not it actually improves outcome, I am not alleging that, but if you're looking to get a pulse back, epi will help you. It's a very potent vasopressor. So you can repeat that at the 0.01 mg per kg dose every 5 minutes. Now, when it comes to drug dosing in peds, just to say, it's very hard to remember these things, especially when you're talking about a crashing kid. Get your Broslow tape.
Yes,
have a system to make this like brainless for you so you don't have to worry about it. But technically, here are the doses of your drugs here. You can consider is the word meaning that it probably won't work. So if you want to give atropine, go right ahead. You can repeat it once. But remember, these are all temporizing measures to kind of support the perfusion, but they're not fixing anything. So we have to continue to think about what is going on here. What can I actually do to reverse these things? Now, pediatric arrhythmias are not that common, but they can happen, especially as babies are experiencing hypoxia, etc. So remember, anytime you see VF or VTAC, we are going to do two things: CPR and electricity. And if you've forgotten your pediatric doses of electricity, they are here for you. 2 joules per kilo and then 4 joules per kilo, thinking about what's going on underneath, particularly focusing on the respiratory origin. We can give epi in between these things, and if they are in a persistent arrhythmia, we can give amiodarone in kids. It's a 5 mg per kilogram bolus, and you can repeat that twice. That is part of the algorithm.
And I think an important emphasis that you've already mentioned is utilizing things like the Broslow tape. There's apps, there's things on carts. We all know this is stressful, but there's just a lot of resources. I can't do math in my head. I forget drug dosing in kids, especially 3 a.m. if they're critical. So utilize these things, double check yourself, have your nurses double check your dosing, because that's very, very common. Dosing errors are very common in kids.
So if you have a shockable rhythm, even in kids, we go ahead and shock just like we do in adults. We're going to continue with our CPR. We're going to give epinephrine every 3 to 5 minutes, and we're going to think about airway. So if they give you a crashing kid, these are the slides to help remind you of what it is, what are the doses of the things I need to give. But remember to always circle back to what is the underlying cause, particularly looking at respiratory issues and making sure that you're addressing those to give your best chance of a successful resuscitation.